Go ahead.
Okay, welcome back, everybody. Again, thanks to Bill for a wonderful introduction. And you know, the sign of deep knowledge and experience is when the number of slides is small, but the value of the narrative is high. And so Bill has packed an awful lot into a relatively small number of slides. I'm going to be covering some of the same territory, hopefully from a little different perspective, and maybe embellishing it a little bit. I've got more slides, but hopefully less narrative, so that we can stay on track here. You know, my background is as an experimentalist and a product developer. I've had the good fortune of working on products, including during my time at Boston Scientific, on some of their cardiac rhythm management platforms. But I claim no real expertise in security per se, other than what I've learned along the way from folks like Bill. But for me, it's security is simply something that we as developers have to pay attention to in addition to safety. Those of us who have worked in the field know we have to develop products that are safe and efficacious with the increased risks that we see in connected devices. We have to also incorporate security into that. The issue is that we're perhaps not, as Bill has pointed out, we're not really training enough people to meet the demand, and that makes it a very attractive field for folks like yourself, students like yourself, who are learning. Many of you, or some of you at least, I assume, will go into industry. And the more you can learn about medical device, cybersecurity generally, medical device security, the greater the influence that you'll have and growth that you'll have in the industry. So we know that cybercrime is commonplace. It's just a part of our lives, and really it's the last decade or so where that has become so pronounced. And we can look at things, and Bill noted that he was at Target. I can recall my own introduction to this field, dating back, to the 2010s, etc. And the Target breach, which was locally very, very significant because Target was headquartered here. 70 million customers in a single breach, and Target's been subject to several. 70 million is now really a small breach by today's standards. Home Depot, the places that we love, the places that we shop, are all subject to repeated and regular intrusions and breaches. Places like Home Depot, Neiman Marcus back in 2014. And one that I wasn't aware of until recently, this is from July of 2021, Forbes, a LinkedIn breach that exposed 92% of LinkedIn users. And that is a breach that affected 700 million LinkedIn members. So a tenfold increase over that previously mentioned Target breach. And so despite awareness, despite that they've become commonplace, they continue. And that tells us something about the vulnerabilities, about what companies learn and do. And I suspect it speaks to the lack of trained individuals across multiple industries and their ability to help those companies harden their systems against intrusion. And what exists in the retail sector and other high-tech sectors is no less true in healthcare and medical devices. This is from a mid-year Sonic Wall report, a threat report and attack trends. There's a link here. This is a useful an eye-opening resource if you're interested in this. As of mid-year, and I don't know if it was June or July, 304 million ransomware attacks, and Bill's introduced ransomware. We'll talk a little bit about that. Cryptojacking attacks, 51 million, 32 million IoT malware attacks. The trends are significant. Malware attacks continue, but almost every form of attack has now been eclipsed by ransomware attacks. Software that infects a system, encrypts or is placed on a system, encrypts the critical data in place, is followed by a communication with the owner of the system telling them that they're happy to decrypt the data, but it will require the payment of a ransom. And one of the hidden costs of this is that even after, in companies, companies are often predisposed to paying these ransom because they're less expensive than bearing the cost of the intrusion itself, of the loss of the data itself. But part of the problem is that even after payment and after the data is decrypted, there are issues about validating integrity and lost time in bringing the system back up to speed with integrity to preserve availability. And so this is a huge problem, and one that perhaps Bill can opine on in the Q&A session, but one that seems to be, because it's quite lucrative, apparently quite easy to do for many systems, is of continuing, and I would suspect expanding significance across many high-tech businesses. And of course, as Bill has already pointed out, the impact is expanding because of what we call the Internet of Things, IoT. And importantly, that IoT system encompasses more and more hardware and penetrates into our lives more and more. We likely all have smart homes. At least they're smarter than the home I grew up in. If they're not fully automated, you may have a Ring doorbell. You may have a Nest system to control your HVAC. You may have security cameras. You may have door sensors, etc. Many of those devices. Oh, and you've got your Amazon systems. Many of those, whether it's known to you or not, are small computers that are quite powerful and represent access points to your network and require vulnerability or introduce vulnerabilities. And of course, for purposes, for many valuable purposes, more and more medical hardware, medical devices, whether they're implantable or not, are connected to the Internet of Things in a way that creates risk, creates additional risk as well. I often say, and it is still one of my principles, is that within healthcare and medical devices, just because we can connect things doesn't mean we should. And to Bill's point about starting early in the design process, I think one of the things that is often underlooked is the strategic value or even the monetary value of connecting devices when one considers the risk versus the reward. Something else Bill can no doubt opine about. And so one of the things that we know is that the trend is clear. And this wasn't so true 10 years ago. If one were to poll patients and healthcare providers, there was likely a slight positive trend. Certainly, there was an interest in connectivity. But now, well, this is a bit old. It's March of 2017, but still an important statistic. Increasing numbers of patients want digital devices that will help them manage their health. They're looking for connectivity. And the same is true for clinicians. and healthcare providers, because they see the value, the efficiency of having interconnected data with decision making. And of course, the consequences of for better or worse, the consequences of the COVID pandemic are equally clear. And here, consumers, and these are slightly different statistics, but if one looks at pre-pandemic stats, this is from a McKinsey and Company report. In 2019, 11% were using telehealth, and 2 years later, 76% are either using it or they're interested in it. And there, the consumer's perspective is, I don't want to go into a clinic with others where there are sick people who may have COVID if I don't have to. Providers, we see a similar statistic. There is a 50 to 175-fold increase in the number of telehealth visits when compared to pre-pandemic, and 57% of providers view telehealth more favorably than they did before the pandemic, and their comfort with it is increasing as well. And that's an important barrier that we in the healthcare sector, we know, because of the introduction of ERP systems and patient data monitoring that required that physicians learn how to use tablets and do histories online and things. There's a tremendous amount of resistance to that. The pandemic has changed that substantially, and in part because of a little changes that at CMS in terms of reimbursement, and even at the FDA. There's some leniency, and there's some it's easier now for telehealth services and devices to enter the marketplace. And there are some 80 new services that have been introduced over this past probably 18 months, 12 to 18 months. So what contributes to the risk? This is probably not, this is not news to you. There are more devices, often with fairly weak internal security. And this was the case in the early introduction of wireless systems into medical devices. There are more applications, often with software level vulnerabilities. We're storing more information, more personal information on our devices. There's greater interconnectivity, so there's more potential for infection with malware, etc. We're using fewer wires and communicating wirelessly over longer distances. The devices are being left on longer. I can remember the early days in computing when the big debate was whether it was better to turn your computer off or leave it on, if you had a hard drive in particular, just so there's less wear and tear on systems. Systems are now more likely to be always on than not. But one of the things that I think it's important to point out is that it's still the case that a significant, if not the major contributor to cybercrime is still poor cyber hygiene. So we as individuals are still making mistakes, still practicing bad habits that are often the things that create the greatest vulnerabilities. But on the flip side, hackers and cyber criminals are smarter about exploiting those bad habits than perhaps they were ever before. And so if you were to take a personal inventory, and this is something you can do on your own. I ask my students to do it in our classes. How many password protected accounts do you have? You may not know. I can't say reliably that I know every password protected account that I'm associated with, because I've stopped using them, right? Legacy accounts that may reside on a system that I never closed, they may well have very poor password protection at this point because of disuse. They may still be vulnerable, and they still may have some information that I would prefer other people not get. How many of them do you access using the same password How many are protected by two-factor authentication? Now here, if you would think over the last few years, two-factor authentication is now being mandated by many of your service providers, advocated at least and often enforced by service providers. Your university account being an example, but there may be others. How many of your accounts do you share with others in your family, others in your apartment, etc.? Netflix, Hulu, whatever it may be. Do you use a password manager? One of the growth industries is in software to protect passwords, and there are any number of those flavors of those that can be used, but many people don't use them at all. And if they don't, they're storing their passwords on paper, taped to the bottom of their desk, or they're using them in clear text documents that, if obtained, would reveal those to a third party. And finally, then, how many of you have been subject to a phishing attack in the last week? Because one of the things that is increasing, of course, is the sophistication of phishing attacks that pretend to be someone or a system of importance to you. At this time of the season, it might be FedEx, it might be the U.S. The Postal Service, telling you that a vital package can't be delivered unless you log in and correct something. It's just a fake front end that gets you to put in your credentials, predicated on the fact if they send that to 10 million people, they can be assured that a fraction of those really do have a package that needs to get somewhere, and the person may reflexively try to resolve it without realizing that isn't the real FedEx logo, that isn't the real FedEx URL, etc., and that makes their system vulnerable. And if that system, this is something that can affect medical device systems as well, right? It's not just something because of the way that viruses and malware can infiltrate. It's not something that is easily isolated from other critical systems that you may have access to or connect to. So some of the most common causes of data breach are unpatched security vulnerabilities. We'll have an example or two that impacts the medical devices in a few minutes. But poor hygiene, weak passwords, shared passwords, or discovery of passwords through phishing, malware, deliberate insider misuse, the disgruntled employee, or social engineering, someone who has infiltrated a system in order to get access deliberately, but still theft of unencrypted devices with data on board that are either stolen from an employee's vehicle or stolen from work. And so our increased reliance on laptops and notebooks is itself a risk, because those systems are more readily stolen from vehicles and from work. And very few people routinely encrypt their devices because it can have an impact on overall performance. And so, I'm going to go ahead to this, and trust me, I'm not going to go very deep into this because I'd be in water that's way over my head. I simply want to point out, and you all know this, I'm sure, better than I do, that communications systems, the models of communication, are multi-layered, and each layer has its own risk and vulnerability. And so it took me some time to appreciate this. The real sophistication and complexity of computer communications, whether wired or wireless, and the vulnerabilities that are created at each layer, unique vulnerabilities created at each layer, right? And that is what makes it so complicated. It could be argued that some medical devices, particularly embedded medical or implanted medical devices, are on the one hand simpler and might represent less vulnerability. On the other hand, they're smaller. They run on less power. They have simpler systems with less room for security, and they're more vulnerable. Well, cybercrime has evolved over the years, and you know, it's probably the case that many of you aren't old enough to remember sort of the early days of cybercrime and hackers who were doing this for the pleasure of showing their technical prowess back in the 70s. But without dwelling on this, over a period of several decades, this advanced very quickly to include, you know, viruses, which were at one time the most significant form of intrusion into computer systems, to worms, Trojan horses or Trojans, malicious code, other approaches to infiltrate systems. To in the 2010s, the introduction of or expansion of denial of service attacks, ransomware attacks, etc. And increasingly, we see outright application of technologies for what we would call cyber warfare at a high level. And again, I've already mentioned the introduction of ransomware. It's worth pointing out that there was a time, and it still continues, but where identity theft, at least in healthcare, was a significant issue because of the relative high value of personal health data in the aggregation of that data, as well as, you know, financial data, et cetera, in your medical records and in your personal data. Stealing your identity gave access to many other things at your expense. You know, there was a time when hackers were motivated by a desire for fame. Today, they're more interested in fortune, but increasingly, the motivation is now political or ideological, if we might say that, becoming increasingly sophisticated, often with tied to organized crime with significant, nearly infinite financial resources, if it's at the nation state level, well planned and executed at unprecedented levels, often, or sometimes for espionage or for sabotage. So it is still, as Bill said, not to you know, awfulize the situation. It's still the case that medical devices are really not often, medical devices are not often a direct subject to attack. Healthcare systems might be, and there are consequences in terms of availability and performance of devices that need to be considered, but they still tend to be collateral damage in cybercrime, not the direct target of cybercrime. So just a few examples, just to again emphasize what I've already said. You know, there have been many breaches that are the result of lost or stolen devices. Medical student with a lost hard drive working on a clinical study with thousands of patient names and health data. Laptops by a business associate or somebody doing business with a hospital, etc. Leaves the laptop, it's unencrypted, it's stolen, has data from many hospitals and many thousands of patients. Turns out the laptop had a you know, poor password protection. Of course, another example of a breach can be an external attack, and here's an example from 2014 in which a Texas healthcare system was infiltrated from externally, and 405,000 patient records were impacted. And at that time, it was one of the biggest HIPAA security breaches that had been reported. Again, we mentioned ransomware. This is not a ransomware attack. This sort of predates ransomware, but has the same intent, and that is that cyber criminals can identify targets of interest, and one, maybe not surprisingly, might be the data records from a cosmetic surgery, a clinic doing cosmetic surgery. And in this case, which was in the UK, 500,000, the data from 500,000 patients was stolen and reviewed. Individuals were identified and then subject to blackmail schemes, because people like to most likely keep their knowledge of their cosmetic surgery a secret. There was an example in Los Angeles, California. It's another example where celebrity records were stolen, and then ransom was expected. So these are often very calculated, run by international criminal gangs, can be very sophisticated, and I won't dwell on it. But it is one of the things that has led to this new trend in ransomware. Things, and there's been great substantial expansion since then. But things like CryptoLocker, software designed to infiltrate a system and search for and then encrypt data. And so finally, let's talk just a bit about, we'll move on here soon, but we'll talk about medical devices. It's interesting because it is often, in the early days, considered not an IT responsibility, but an IT problem, because these were devices designed and then put on the network without much input from the IT departments at the healthcare provider, let's say. And they were networked, but they might be poorly protected, lack of malware protection, poorly patched, and subject to becoming, again, collateral damage if a system is infiltrated, and then and that can affect this device because of poor protection. These sometimes contain personal or private health information, but are often not part of a security. Back in the day, were not part of a security risk analysis. So designed, and again, the designers didn't even think it would be an issue, because who would want to steal that data or have access to it? Those thoughts have changed, and as Bill points out, the regulatory agencies have taken a different view of it. And part of it is because of differences in IT and the biomed priorities. Introducing them into a system in a way that's not consistent with IT's needs for standardization. Right? Biomed priority is operational and patient safety. And as Bill points out, you can't have, if you have dual factor authentication on an infusion pump or a critical life-sustaining device, that could become a risk if authentication can't take place. So why does it matter? It matters because, on the one hand, it can impact patients' lives directly, but also for the healthcare providers, it's important because there are significant penalties for breaches. And these are the things that healthcare organizations really pay attention to. And the Health and Human Services still maintains a wall of shame that reports all breaches over 500 records within 60 days. There's a running list. You can go visit it. And the statistics really are staggering. There's been a 36% increase since 2019. Healthcare providers showing the largest increase, 42%. Now accounts for 78% of reported breaches. Again, this is a shift from retail, Target, Home Depot, etc., to healthcare providers. And in 10 years of recording, there have been 3,060 breaches of more than 500 records. More than 237 million patient records have been compromised in that period of time. And the data, what I don't have, and it might relate to Bill's statistic, is the cost, the overall cost to the healthcare system. But it is in the billions. I think Bill's statistic was 5.5 or 5.1 billion. It is of course much higher than that in aggregate. So it's a jungle out there. And this is an old, I didn't update this slide. This is a slide from 2018. You can go to this site, healthcareitnews.com, and you will see a running list and an annualized list. But it is striking, the exposure and the attempted and successful healthcare breaches that result in both steep fines to the organizations, but the exposure of critical health data. And so it isn't just about medical devices, it's about the healthcare infrastructure and the importance of security in that realm. And again, not to beat a dead horse here, but we've seen this enormous change in the approach to cybercrime. And 2016 is really viewed as a pivotal year, certainly when it comes to ransomware. 2014, there were really no ransomware attacks, or very few. 340,000 in 2015. 463,000 plus in 2016. I don't have a current statistic, but in the 5-6 years since then, it is undoubtedly grown dramatically. So what about medical devices? And I agree wholeheartly with Bill. This is an area that can be easily hyped, if you will, that people get concerned about, the press can get concerned about, and it's important to understand the difference between perceived risk, theoretical risk, and actual risk. But we should act on theoretical risk, not panic, but act on it, so that we don't have to respond and panic by real occurrences or real events that take place. While computer-related failures are known to play a significant role in deaths and injuries involving medical devices, there really are no similar reporting systems that meaningfully capture security-related failures in medical devices. And this is from a very early publication by Kevin Fu, who Bill has already mentioned as the founder of the Archimedes Center, really one of the pioneers in this field. And his point here was that it's actually quite hard to know if a security issue has led to a failure of a medical device, because there really isn't a supporting system or a reporting system. Now you may know, and I don't know if Bill mentioned it, but Kevin Fu is now the interim head. I think he's still interim head of cybersecurity at the FDA. He's on loan there from the University of Michigan. And in the period of 2006 to 2011, there were 5,294 recalls, some voluntary, some required by the FDA, 1.2 million adverse events through what's called the MAUD database, which is a database of adverse events that are reported by users to the FDA. 23% of these recalls were computer related. 94% reflected medium to high risk of severe health consequences. There's no systematic collection of data, what you might call, fault analysis or failure analysis to know the critical events that led to those recalls, and what the impact was, the specific impact was on availability of function or on performance, okay? And I think this is an area of increasing importance because without understanding the nature of the failures, it's difficult to know how to avoid them moving forward. So just a couple of examples, and admittedly, these are fairly old. And part of that is simply that I haven't updated them as religiously as I should have. The other is that to some extent they represent the world as it was, and in some cases still is, in terms of lack of preparedness for the risks that we've seen. And so one of the early examples was a VA hospital, a cath lab in New Jersey that had to be closed in 2010 when malware infected a computer system for devices that included their X-ray systems. Now, this was a computer system that was being run by a PC of some kind, and was running, an off-the-shelf OS, perhaps. I'm not sure. But it wasn't the target, but malware enters a system and then spreads from computer to computer, and these systems became affected. They probably weren't the primary target. They were collateral damage, but the fact is that once infected, their performance was impacted. So there were 327 devices infected with malware. They included devices from GE, Siemens, and Philips, so agnostic with respect to the manufacturer. But the impact was an inability to provide appropriate care at that lab during some period of time. Now, that has a monetary effect, right? Has a financial impact, but for veterans who need access to that lab, it's very difficult to know what the downstream effects were. They had to go somewhere else. They delayed their care, and those things can have consequences to individual health. Example 2, not to pick on the VA system, but a VA hospital in Tampa, Florida. 104 medical devices were infected with a botnet worm, and again, Conficker is a well-known botnet. I don't think I go into this in any greater detail, but you all may know about such things more than I do anyway. But it's a botnet worm that enters a system, replicates, and then is sent to other systems. There were 104 medical devices infected, including X-ray, mammography, and gamma cameras for nuclear imaging. That had to be taken out of service, at least temporarily, because of the infection. And this one is striking because it's from 2012, which may seem like a long time ago to you, but not to me. So this was Beth Israel Deaconess Medical Center in Boston, a very well-known institution that reported to NIST issues with their own security, and this was through a security advisory board report that found that 664 medical devices, and here medical devices, we're not talking about implants, we're talking about devices used in the hospital setting, in clinic, diagnostic, or other devices. 664 were running Windows as an off-the-shelf system, and then running some vendor-specific software. But in 2012, 600 of them were running Windows XP. None of them were running even Service Pack 1. And again, many of you are probably not old enough to remember Windows XP. or the Service Pack 1, Service Pack 2, etc. But in 2012, they were running a software that hadn't been updated to what was called Service Pack 2. And that support for that service pack ended some 6 years before then. So they were 6 years out of date on the security patches, that software patches to that operating system. 15 machines were running Service Pack 2, but support for that ended in 2010, and only one machine was running Service Pack 3, and that was the only current one because it was going to end its service life in 2014, and this is simultaneously humorous, maybe, but also of concern. One MRI machine was still running Windows 95. Bill might not even be old enough to remember Windows 95, but I certainly am. So that represents the level of vulnerability as recently as 2012. And while I haven't done much additional research since then, I will tell you that I do hear anecdotal reports from from peers, et cetera, that there are still systems, there's still healthcare delivery systems that are running systems with very, very old software or operating systems that are vulnerable. And research labs in academic institutions may still be running systems that are vulnerable as well. And if you're at an academic institution like the University of Minnesota, and you're tied, or your work is related to work going on at the Fairview, in the Fairview hospital system, there may be vulnerabilities. It's one of the reasons that I hold an appointment in the Department of Surgery, and when I got that appointment, my system, in terms of the protocols that I have to have in place on my system, were upgraded significantly for that reason. And as I've learned, it's not because I said, well, I'm not a physician. I said, I don't see patient records. That's not necessarily the concern that I have direct access, but because I might have access to Department of Surgery resources and connectivity, that my systems might become a path to vulnerability for some other system, and they just want to avoid that, obviously. So I'm going to skip over this point because I'm going to make an assumption here that you actually know about the Conficker botnet more than I do, and could probably teach me about it. So again, I don't want to get into too deep water here, except to say that, again, I'll just show this, that what's interesting is, somebody creates this botnet. It can infect other computers. It replicates, communicates with a command and control servers. Who knows? It could be in Russia, in China, the Ukraine, wherever they are, but sends commands back. It periodically updates those bots, and then can systematically launch attacks under coordinated control, spread the infection, but then also begin to look for valuable data. And so why hack a healthcare system? It could be ideological or political. It could be coincidental or collateral damage. I suspect that it's still mostly, it is often coincidental or collateral damage. It's increasingly for this, and it's generally not ideological or political. It could be usually driven by a desire to steal and monetize medical or patient information so they can sell it, to steal insurance, credit card information so they can use it, sometimes, and I think this is undervalued, it's an area of interest to me, it may be to gain access to intellectual property in the form of medical research or product development, and something that I write about and speak about is the risk for medical device companies running pivotal clinical trials, important clinical trials. The increased outsourcing and global expansion of those trials that involve multiple centers, and the vulnerability that are created for intellectual property theft and the potential impact on brand and on value for companies of failing to protect their clinical data while it's being collected, broadly in partnership with clinicians around the world. So I want to talk about one other breach example. I'm going to do this quickly, but it is important to understand that this notion of what's called an advanced persistent threat, I think it would be fair to say that botnets like Conficker fall to some extent into this category. But an advanced persistent threat is really different because it is designed to avoid detection for as long as possible. It's an advanced persistent threat. And there are increasing examples of this. And, small hospital is just an example. Small hospital was subject to a sophisticated attack. It only netted 5,000 patient data capture, data records, but it qualifies because of the nature. It involved infiltration in which there was capture, encryption, and stored screenshots with critical information on it that could be, and these were stored locally, but then exfiltrated at some point when the volume of the data was optimized, and it's exfiltrated, and the perpetrators are gone, often before the owner of the systems knows they've been subject to a breach. What is it? It's a form of cybercrime that often targets business and political targets, requires a high degree of stealthiness over a prolonged period of operation in order to be successful. The objectives typically are not really immediate financial gain. For example, it's not, hey, we've got your data, give us money or we won't give it back. It's about compromising systems on a continuing basis so that you can learn more and more about the system, dig deeper, take more valuable data, sometimes not being revealed at all or only after the fact, and using that data not for ransom, but use it for your own financial gain. Often selling it to others on a black market, for example. So it involves incursion into a system. And here that incursion may involve social engineering that's designed to deliver targeted malware to vulnerable systems and people. Social engineering, which might be getting to know people, penetrating the system by looking through the garbage, by placing somebody on site during a vendor visit or hiring them in, where they have access and can, within the company, physically or not, or electronically, search for vulnerable systems and individuals. Sometimes that's using zero-day vulnerabilities. You know, again, better than I what those are, but they're just first of a kind vulnerability that's never been used before, so nobody can protect against it if it's never adequately, if it's never been used. Sql injection, that is using inputting commands remotely that are interpreted by the system as legitimate and essentially cause things to happen locally. Discovery, Once in, the attackers want to avoid detection. They map the organization's defenses from the inside. They create a strategy for how they're going to manipulate that system or exploit it. They sometimes will have methods of diversion in place, so that sort of false ends to lead people in different directions while they're going about their business. They capture unprotected systems, capture the information they want over extended periods of times. It often involves new malware to secretly acquire data or disrupt operations, and then finally they exfiltrate that data. It's moved off of. It may be stored temporarily on the victim's own machine, and then moved out over some period of time, so that if it's detected, it's not detected until it's too late to avoid to secure the data. So I think one of the things that Bill alluded to that I'll talk a little bit about is some people, we call it the dark web. I'm not going to go into detail. I only have this slide in here to note that for most of us, we operate in a domain, a portion of the internet that is public and well known, and we use portals like Google, Amazon, or Yahoo that are well known and public. But there is a deeper part that is not so public, or is not public, that involves private networks run by governments, etc., that is not readily accessible. And then we have the dark web, where there are sites that most of us would never know about unless we had either a need or a desire to know about them. But that's where a lot of activity takes place, and it may take place behind substantial infrastructure that obscures the identity of whoever, your identity if you're on that system. And it leads to these things that Bill's mentioned, which is that there's commercial activity in which hackers can use tools. These tools are available to develop and test new threats. They use tools to sort of anonymize those. They can be sold and designed to do things that a particular customer wants them to do. And so a whole industry exists to help malware authors both design, test, and then implement and evade detection. And again, many of you may have learned more about this as software engineers than I will ever know. And so one of the things that, again, you may know about again, not to be an alarmist, because I think systems like there's a system, a website called Shodan, and here a publication. This is back from 2013. Scariest search engine on the internet. I sometimes do a demo with my students and go there. I'm not going to do that. And if you go there, you should be careful. It is interesting to visit because you can search for devices, network devices around the world. You can do so by corporate name, etc. And one of the things that you'll find is information about the various services and servers that are being run, their version, and smart hackers know the vulnerabilities of legacy server systems, and that can create information about their vulnerability. It may have information about default passwords and the state of security on that system. Now, it is published ostensibly as a vehicle to help well-intended IT professionals identify vulnerabilities in their system, but its accessibility also creates a possibility that it can be used to do harm. So, but it's an interesting, if you're not aware of it, it's interesting, check it out or at least read about it. So I'm running a little late here, but I'm gonna get through these because now we're getting to sort of the commonality with Bill's, some of Bill's topics as well. But what about implantable medical devices? And increasingly, wireless implantable devices can be found, throughout the connected to many systems in the body. Certainly, cardiac pacemakers are something that have been in the press and are of interest. But similar devices would include deep brain neurostimulators. They're based on some of the same technology. Gastric stimulators. Those are less common devices, but they're built on a similar platform. But others, cochlear implants, and Bill mentioned insulin pumps or drug infusion pumps. Those are both personalized devices in closed loop diabetes management systems or hospital systems for in the clinic, infusing patients with critical healing or life-saving drugs. Now, I think in the interest of time, I'm gonna see. Hopefully, this will work. Now, I'm sharing these. Sort of, it's to illustrate in some respects the hype side of this field. Back in the mid 2000s, but one of the characters that was prominent in the early days was a he would consider himself a white hat hacker, Barnaby Jack, who was the first to disclose an infusion pump hack. I think it was Hosperia, but they'll probably say here. So this is just a short video from Bloomberg, and hopefully it'll run.
Bank accounts and personal information. That's what we usually think of when we hear about hacking. But we can now add medical devices to the list. Bloomberg's John Ehrlichman caught up with a hacker turned computer security expert who says that insulin pumps are especially vulnerable and the results could be fatal.
I have a vulnerability which will let me acquire the serial number from any of these insulin pumps within a 100-meter range.
And that's this thing right here.
Yeah, so this is my software which exploits that vulnerability to actually return the IDs of any insulin pumps in that range. From 100 meters away, I can scan for any insulin pumps in the vicinity. I will return those insulin pump IDs, and then I can have them dispense the entire 300 units of insulin, which for a type 1 diabetic will easily prove fatal unless you seek immediate medical attention.
Most patients think they can turn off wireless capability, or that safety mechanisms will warn them of an attack.
What they don't realize is that I actually disable all of these warnings, and that the RF functionality cannot be turned off. It's always listening. Even if you turn off the remote option on the pump, this attack will still work because the RF transmitter is always listening.
Medtronic, the company that makes this insulin pump, says it is increasingly focused on security, but says at this time, we believe that the risk is low and the benefits of the therapy to people with diabetes outweigh the risk of an individual criminal attack. Medtronic may fix the software in the next version of their insulin pump, but there are no plans to recall the devices. The Food and Drug Administration, the federal agency tasked with policing the $95 billion U.S. medical devices industry, told Bloomberg current adverse event data do not indicate that breaches of device security measures is a widespread problem. But Jack believes there should be a recall.
I'm trying to go as public with this research as I can, just to show how easily these pumps can actually be attacked, and hopefully change the mind of the FDA and of Medtronic and of the public that maybe a recall could be in order.
John Olson, Bloomberg, San Francisco.
And I had forgotten that it was a Medtronic pump. So I suspect Bill can share some important insights on this.
I
Yeah,
I'm
go ahead,
sorry.
Bill.
I just have to jump here for a second.
Sure.
Yes, indeed. I was in the middle of that at Medtronic. I was
Okay.
director of product security at the time. Barnaby Jack was a very interesting guy. He and I think he would say that we turned out to be friends. That little statement that they read, I helped write that.
Okay.
Barnaby Jack was really a remarkable guy. Another interesting sort of sad story is.
Hey, Bill, don't tell it. Don't do. That's my. Don't give away the goods yet.
All right, I won't say a thing. Sorry, I just had to jump in there. It was like old home week for me. Sorry.
Well, I'm glad you did. I'm glad you did, and maybe in the Q&A we can chat about that even a little more, because I think you were right at the epicenter of that in the early days, which is one of the reasons that you've got the prominence that you have. But I'm going to share, because for me, part of this in the popular press, right, in the lay public, we know today conspiracy theories thrive. Well, they were thriving back then as well. And so one of the things that really led to even heightened anxiety around disclosures like this have to do with that sad story that you were about to tell. So, and I invite you to talk more about it, but maybe we can do so after this little clip.
Conspiracy theories are now developing in the death of a Bay Area hacker. His name is Barnaby Jack, and he once made cash fly out of ATMs by hacking them. And he was about to reveal the vulnerability of pacemakers when he died last week. Here, ABC News reporter Lindsay Davis picks up the story from there.
His pacemaker can be wirelessly accessed with that number.
It was the shocking plot twist on the hit show Homeland.
I'm killing you.
That scene got many wondering, is it actually possible to hack implantable medical devices, specifically pacemakers? According to this man, the answer is yes. Professional hacker Barnaby Jack was set to reveal the secrets of just how it can be done this past weekend, until he mysteriously turned up dead. Just days before the 35-year-old was to speak on hacking humans at a major Las Vegas hacking convention,
he was able to remotely exploit them. And this talk was really dedicated to how the manufacturers could improve the security of the devices.
His girlfriend discovered his body in his San Francisco home on July 25th. Now the coroner's office is trying to determine just how Jack died. Jack dedicated his career to using his skills to expose vulnerabilities hackers can attack, helping manufacturers develop tighter safety measures.
He wanted to know, how could that stuff down there fail? And especially, how could it fail if there were some not nice people out there trying to make it crash?
As for Jack's warning about hackable implants, the FDA says there is no cause for alarm for the nearly 3 million Americans who have pacemakers, saying it is not aware of any patient injuries or deaths associated with these incidents, nor do we have any indication that any specific devices or systems in clinical use have been purposely targeted at this time.
If you go to the dark side of this, could unleash the ability people to commit murder, in effect, to speed up pacemakers, shut them down.
Meanwhile, some are now left wondering whether he could have been purposely targeted over his life's work.
Lindsay Davis reporting. Conspiracy theory.
Okay. And I'll turn it over to you, Bill, but I just want to say what's striking, and the point I try to make is that, and I think this is appropriate audience, right? As knowledgeable, trained professionals in high-tech industries, and certainly in this field, it is really incumbent upon us all to apply reason thoughtfully, and to often not get sort of caught up in conspiracy theories, and the juxtaposition of events is not always as they seem to be. So, Bill, I didn't know that you were a personal acquaintance or friend to Barnaby Jack. So you can tell us now, because it is a sad story. So tell us a little bit about the circumstances, or what you know.
It really is sad. Barnaby Jack was one of the premier, he and one other guy were kind of the premier researchers bringing these issues to the fore about medical devices. And it was a time, like you said, you know, people saw this in the news. My gosh, they knew how to sensationalize it like never before. They always made it sound worse than it was. I have to say too, that scene from Homeland, I can't tell you how many interviews I had to do because of that, and how many calls we got, and how much time I had to spend with our public relations people because of that Homeland. That still comes up occasionally. People refer back to that Homeland issue, and probably nobody even saw it or knew about it, but it was a scene where somebody took over the vice president's pacemaker and killed him, which is just, it was totally implausible. But oh my gosh, did the press jump on that? I spent so much time managing that. Anyway, Barnaby Jack, we actually invited him to Medtronic. He spent a day with us at Medtronic about 6-8 months prior to that. And in fact, the time that they were just talking about, he was about to go to Black Hat, which is the big hackers convention and the biggest convention in the world, and was going to do a presentation. As it turned out, on another company's pacemaker system. Doesn't matter. It was, you know, we all care about it. But as it turns out, the day before, he had spent about 3 hours with us on a video chat, telling us about the vulnerability that he discovered and what he had learned about the competitor's device without giving it away, without giving out too much detail. And so we felt really well prepared. You know, we were ready and we understood. And what he brought was a legitimate concern, you know, that could have easily been our device. It turns out it was somebody else's. Anyway, we finished up with him about 6 o'clock at night. And the next morning I got up and he had died.
Yeah.
And it in the long story, or the short version of the story, is he lived a pretty wild life. He did a lot of drinking and a lot of pills and a lot of other drugs, and that's essentially what ultimately did him in.
Yeah, it is sad. With fame comes you know, some liabilities. I often wondered, because this is a really, really important part of the story, right? Which is not, I mean, this audience is hearing this, this little inside view, probably for the first time. I was not aware, because I always wondered why it was never, if it was true that he had identified a vulnerability, why it wasn't subsequently revealed by a peer or something. But you're saying maybe it was. I mean, it was obviously made to you. Did what he said he was going to do ultimately, I mean, did it become available to the public? Was it disclosed ever?
I don't know that it was publicly disclosed, but the manufacturer definitely was made aware of it and took action. And I can tell you, Medtronic and the other premier manufacturer, we all looked at our systems to make sure that we weren't vulnerable in the same way. And so some adjustments were made on our systems too.
Yeah.
So it was a legitimate threat. It wasn't a serious one in that the likelihood of it happening was extremely small. But yeah, the original manufacturer that he had done the research on, they definitely were made aware of it and you know, did the research and took necessary action without it being a big public event.
Right. Well, that's good. And again, I think, that's an important part of the story. So I really appreciate hearing it from you. And I look forward to learning more about it as well. We talk a lot, and you talk a lot about transparency and about reporting vulnerabilities and things. I think one of the things that's important is that we you know, companies can't be penalized. If companies are penalized, if their brand is penalized, if they're penalized financially by disclosure, it can have a chilling effect. As for example, we know in healthcare, the recent disclosure of the Omicron you know, the disclosure of the first Omicron COVID-19 case, you know, led to some pushback. I forget which country the first one was wasn't New Zealand, was it? But wherever it was disclosed, I mean, it had some the disclosure itself had some implications, and so I think part of the creating vulnerability is or creating transparency is in ensuring sort of mature adults are in charge and aren't going to overhype or overspin it in ways that can lead then to consequences that make people not want to disclose it.
It's exactly right. Now, maturity is the right word here. Now that, we're down the road here 10, 12, 14, 15 years, this market has matured quite a bit. Two things. One is that all of the manufacturers realize that what's bad for one manufacturer is bad for all manufacturers, that it hurts the integrity of the whole idea of a medical device. And so while at first it was sort of thought of a competitive disadvantage, it's not the case anymore. We all talk openly about what's going on at each of the companies, and disclosing is the best interest. Secondly, it's become routine now. In fact, if you go to Philips or Medtronic or Abbott or Boston Scientific sites, they actually have pages on their site where they disclose every vulnerability and the impact that it might have. There's always a statement about just about every major vulnerability. And so disclosing is no longer a curse word. And in fact, I think the fact that the reply is done openly and that the information is provided widely, I think just proves that the security is taken seriously and that there's no reason to panic.
Probably ensures too that it isn't just the press that maybe that in some cases is prone to exuberance, isn't the only channel, for education, because then what we see are clips from movies, that sort of awfulize it. It's better to do it in a sane and consistent manner. So excellent. Well, I think I've done. Yeah, go ahead.
I was just going to say, I'm to the point where, I still get asked to do interviews and so forth, or I get asked advice on, and I just say, don't talk, because there still are, especially with a person from the press who's looking at this for the very first time, you can tell they're pretty excited, and I just do not talk to them because it really gets taken out of context.
Yeah. It's as an interesting aside, and you may not yet be aware of this. We don't do it in my program, but that Mike Johnson, DGS for security technology, they in their technical communications class, they actually cover sort of press conferences and writing press releases, and really because of the nuanced nature of this, they teach the students about how to address these things. Who, how, when, and things like that. So really important stuff. I'm on to my last couple of slides here, but I really do want to sort of finish up with and this is a colleague of Bill's. Again, I've set up one of the pioneers in this field, Kevin Wu, really, and this followed not too long on the heels of the Barnaby Jack. I don't think it preceded it, but it wasn't too long after that Kevin Fu's group, he was then at the University of Massachusetts. This is before his time at University of Michigan, published on pacemakers and implantable cardiac defibrillators, and about their effort and demonstration, proof of concept for hacking them. That was really quite striking. But what I liked about it, and again, I'm going to be over my head on some of the engineering here, but what I think is that quite different than what Barnaby Jack or what you might find in the press. This was a scholarly publication describing in some detail the design of a system and how they accomplished what they were able to do, and the limitations of it. And essentially what they did is constructed a system, I think it was a 2-component system, a near field device, and then a control system or a computer system that analyzed the data for both capturing data from a pacemaker via radio, via air transmission, decoding it and then modifying it so that they could influence the system itself. I think this is this is a must read for people in this field, and I would encourage everybody in the audience to read it. I like it because it's a crossover to some of my own work in terms of sort of preclinical and using tissue for experimentation. Here they used like a side of beef, I think, a bag containing bacon and ground beef, really to simulate the depth of the human chest, the chest wall, to try to act as accurately as possible. Create a system that mirrored the penetration requirements of a radio signal. These are really low power devices, but they characterize this very carefully, and I applaud them for doing that. And again, I'm not going to get the details in this. I'll leave that to the audience, simply to say that they captured and were able, with their knowledge, to decode the signal. And having done so, to then reprogram the device. And again, the audience may not know that these devices, most of them, because they're implanted, they have to be programmable externally. In the old days, that was a coil, an inductive device placed right over the pacemaker on the chest. But when I was at Boston Scientific, and it was the Latitude system we were preparing to launch, we had ambulatory, and I was in charge of the preclinical facility. We had ambulatory dogs that we could monitor and program in the room. They could be going about their business, and we could be altering their system. So they became, a larger gap over the air of the system. And what they demonstrated is that they could replicate with just a simple radio eavesdropper. They could get information from that system, but with a software radio programmer, a little more complex device, they could effectively duplicate all of the functions of a commercial programmer, that would be manufactured to connect specifically with that system. Some had an impact on privacy, but critical functions had an impact on integrity and performance. And so for me at the time, this was, a research level engineering validation of vulnerabilities that previously, was at least publicly only known through people like Barnaby Jack and through the press. So it was an important publication. And it was a very, quite a small antenna-based device that they were using. Okay, so I'm going to wrap up here. Bill's covered this excellently, so I'm not going to cover it in depth, except to say that one of the things that I know, because I got involved in 2013, 2014, was that was about the time that the FDA was really beginning. Even though they published, I think in 2006, their guidance on off-the-shelf software, is when they really started looking seriously at devices, including implantable medical devices. Bill's already talked about these. These are the big three. The FDA has really led globally on this topic, as Bill has taught me. And these are probably the three guidance documents that you should be most aware of. And because almost everything else, and Bill can correct me if I'm wrong, almost everything else globally has its roots in the work that was done, in the production of these three documents. And I'll leave it there. And then I'm going to talk about something that I think Bill, this might be the first time Bill's hearing a little bit about this, and I don't want to claim more than is right. I'm going to give the bulk of the credit really to my colleague at the time, a senior fellow in TLI back in 2013, 2014, when I was brought on board. Gopal Kannan, who's now back at the university at Carlson, invited me to work with him on efforts to explore medical device cybersecurity. And I was very excited about it. We didn't quite have the sustained support at the university that we have now. But I like to think we did. This is Gopal, my colleague Gopal Kannan. I think we did some good work. We held a series of roundtables. I certainly learned a lot during those roundtables, meeting with stakeholders from government, from healthcare, from the medtech industry. Gavin O'Brien at NIST was heavily involved. Axel Worth, who I know Bill knows, was then at Symantec. We had folks from Fairview and Alina, and we had the founder of MDIS, whose name is escaping me, but we had
Dale Nordenberg.
Yes, Dale was involved, a physician, in fact, a trained physician who was leading that organization. And you know, as a group, we developed the first use case for network medical devices. We focused on infusion pumps. That was published in draft form by NIST in 2014. And some of that work ultimately found its way into, I believe, SP 1808 that was published by NIST in 2018. And really, what I learned and what I think the stakeholders learned, and we had somebody from the FDA there too, but I can't recall who was involved. But the take home for us then, and it has come to pass, is that this is really shared responsibility by regulatory agencies, by manufacturers, both of finished goods and of components that manufacturers depend on, by providers, by patients, and even insurers, and that's a little less transparent to me, but maybe Bill knows a little bit also about the payers. Payers, the folks who really pay the bills on behalf of patients. And so for me, my participation, Bill's presence at the university, the creation of the CMDC is important and exciting to me because it is the fulfillment of something I was interested in and thought was important in Minnesota and at the University of Minnesota back in 2013 and 2014. And the wheels sometimes turn slowly, but slowly or not, the U is now and the center under Bill's leadership is in a position to really make a difference. And so I get excited when Bill gets excited because we're in a position to do something that we've not been able to do before. So I've got one concluding slide here, just saying things that we've already said. Healthcare system networks are extension of a broader Internet of Things. Interconnectivity has its merits. As a result of COVID, the need for interconnectivity is greater than ever before. I personally do not believe we'll ever go back to where we were. So mobile health and telehealth are critically important and will remain so for the foreseeable future. FDA has clearly taken a leadership position. We should be proud of that because they often don't get the credit they deserve in many areas. Really advancing the cause of security as being as important as safety, and indeed influencing safety. Stakeholders all have a role to play. I would suggest that engineers and scientists, software engineers in the industry have a particularly important role to play, and it's one of the reasons that it's important for you as students to learn about this field, particularly if you're going to be working in it, so that you can have the greatest influence and the greatest impact on the field and on the devices that are being deployed, and through that benefit your employer, the manufacturers, benefit your employer healthcare delivery systems, etc. I'm going to end with one slide just to a pitch for a technological leadership institute. Now, students, as I understand it, you're in master's degree program. So this isn't a pitch for you to join our programs, but I would say, we do have some courses in our programs that might be suitable electives for you. Maybe not, but it is an important way that if you're interested in this field, we certainly like to know of your interest, and we're certainly I don't want to speak for Bill here. Bill's the managing director of the CMDC, which now lives in TLI. But I'm certainly interested in learning from my colleagues in the MSSE program faculty, how we might collaborate most effectively across our programs. We have a unique role that we play. We really prepare scientists and engineers to lead innovation and growth in high-tech industries. Most of our students are already working in the industry often. We've got a management technology program, a securities technology that includes an option for a cybersecurity minor. And then I run the medical device innovations program. And I'd like my program in partnership with Bill and the security technologies program, to play a more significant role in this field. And I certainly look forward to that. So with that, I'm gonna and as well, I want to thank Bill again for joining me and sharing his knowledge. I want to thank Kevin for inviting us, giving us this opportunity. It's been my pleasure. And I'll open it up to, I'll turn it back over to Kevin, and then open it up for any questions that you might have of Bill or I.
And can you see the question in the chat?
Oh, let me pull that up. Let's see. And Bill, you might want to look at the chat too. Does fragmentation in hospitals, healthcare providers support or harm security? Smaller attack surface versus outdated or lacking in standards? Well, so I'm going to let Bill take a crack at that. I'm only going to ask for maybe clarification on what they mean by fragmentation, because in my knowledge and experience, we're seeing not fragmentation but consolidation. So maybe I would benefit from a little more detail about what is meant here by fragmentation. But Bill, do you want to take a shot at this?
I have the same question about exactly what you mean by fragmentation. All I would say is that complexity means is an enemy to security. That the more fragmented or complex a system is, the more difficult it is to secure. So on a core level, the fact that hospitals, like I mentioned, if you've seen one hospital, you've seen one hospital, that is definitely not in the favor of security, of each of them being different and using a different mix of products in their hospital, et cetera. Yeah, they're fragmented. I guess I'm saying basically the same thing. The fact that healthcare is very much that way, although Dan, you're right, there is consolidation. There is far more consolidation than there used to be, but it's still a hyper complex environment, and that is the enemy of security.
And what I'd add to that is, and as a part of that complexity, one of the things that I've certainly seen, even in devices that I've been involved in developing, is the rate of technology advancement and the rate in change in those devices, which makes it increasingly difficult for a system, any system, to avoid fragmentation and to ensure backward compatibility. I mean, companies can't. How often do we does Apple release a new iPhone? In the medical field, systems might not be updated quite that quickly, but the rate of change and the advancement is so rapid that it is not really financially viable for even a hospital system to ensure that its hardware is not fragmented and is always the latest and the greatest. And I believe it's one of the reasons that to Bill's earlier point, the needs have to be security by design, an understanding with a clear upgrade path, responsibility for patching and upgrade paths. Even if some devices are old and some devices are new, there has to be a path to keep those current from a security standpoint, if possible. And maybe, Bill, you can comment on this. I don't know what can be done about mandatory obsolescence of devices. I do know that I think it was, I want to say Hospira, but I'm in danger of identifying the company poorly. Some of the very early infusion pumps were shipped with hardware with default password credentials, username and password credentials that were essentially in firmware and couldn't be changed. And then that sort of negatively impacts the ability to secure them once they're in place. So anybody who could identify them knew what the password, what the ID and password were. So Bill, any thoughts on that? Are there changes in the marketplace about obsoleting devices, or does that have to come from the FDA?
I don't even know if the FDA can do that. It all comes down to money. The problem is that healthcare is not a high margin business. Hospitals aren't a high margin business. Healthcare makes a lot of money, but hospitals are not a high margin business. And so they don't have the support or funding to replace equipment as quickly as any other business in the world, probably. I mean, like I said earlier, sometimes you can walk the aisles. I used to do that a lot when my wife spent a lot of time at Mayo, and I'd walk around and just look at the devices, and they were really easily 15 or 20 years old. So I think it's a financial thing. And another thing I might add, I was talking to my friend at Abbott, Chris Tyberg at Abbott, who heads the device security program there just recently. And one of the problems is always legacy devices, right? The old devices that weren't built with security in it. And everyone keeps talking about, how do we solve that problem? We've got to get the hospitals to replace them, and we've got to replace them. And what Chris said, I think, is exactly right. There will always be legacy device problems. He said, it's sort of like gravity. It will always be there. And so I don't think that market forces alone are going to change that. I think it's, over a long bit of time, but I just think that manufacturers and healthcare providers and security experts have to come up with some more creative ways to deal with legacy devices, because I don't think that problem's going away anytime soon at all.
Yeah, and I don't know if modularity. One of the things that struck me, of course, is that it's particularly difficult for implantable devices, and one of the reasons. I can recall when some of these CRM devices or ICDs or pacemaker vulnerabilities were revealed. There were people saying, well, and I assume maybe, Bill, patients were calling and saying, should I have my pacemaker removed? And it becomes really problematic. You can't really get into the practice of exposing a person to harm by removing and replacing a pacemaker on a 1 in 10 million, 1 in a billion probability of an event, when the risk of infection and death during anesthesia, et cetera, might be 1 in 10,000, whatever it is.
You're exactly right. And in fact, I was on a number of phone calls where a patient made enough noise that they talked to their doctor, and their doctor, the cardiac surgeon, and the patient, and I and some other people from Medtronic were on a phone call trying to explain. And this person was worried that his device was the same as a wireless router in their house, and that it was just as exposed. And when we finally explained to them, no, there isn't anything like that, that in fact it's far more complex and it's far more proprietary, he relaxed. But you're exactly right. That's what it leads to. And so just changing things for the sake of security or changing things for something other than strictly for the health of the patient just doesn't make sense.
So we've got a couple of other questions. What are good ways to get relevant exposure experience and learn from security from industry after our master's program? Bill?
My answer probably won't be that helpful to you, but I've been thinking about that since I read it. There's a couple different things I can think of. Obviously, read all you can, get involved all you can. What I would say is be curious about it. When you're in a meeting, ask the unaskable, saying, is anybody thinking about security here? Literally, and I mean that sincerely, those are the kinds of questions that need to get asked. When I've hired security people, it wasn't about their technology background, it was more about their curiosity and their desire to figure out how things work and desire to think about who's not thinking about the unthinkable, right? So there's plenty of organizations that are out there that cover security. There's a group called AAMI. There's a group called HISAC. Go to the FDA website. Like I said, I mean, that's the first place I would point you to, is the FDA website. Gives you a good summary of what's going on. look into whatever company you're at. They have a security group, right? Talk to them. Maybe even want to work for them. I mean, there isn't a single hard and fast way. All I can tell you is there's a huge sucking sound in trying to suck people into this industry. And if you show any kind of curiosity or interest in it, I think you'll have plenty of people to talk to about it.
Well, Bill, I'm gonna add something that maybe you're just don't want to appear too parochial in suggesting, but I would say, and the fact is that CMDC launched and Bill and I had the good fortune of participating in it. We launched as a part of our overall mission. We launched a inaugural Introduction to Medical Device Cybersecurity workshop. It was I guess Bill, it ended up being eight sessions over 4 weeks. It will be offered again through to consortium members, but to interested parties. I think it's reasonably inexpensive, and it is crammed with top to bottom with information that's relevant about risk management at both the product development and enterprise level. Bill talks about regulations. I talk a lot about standards. And then we've got others like Ken Hoyme from Boston Scientific, and Mike Johnson, our own enterprise risk management expert, and Andrew Baumet from Boston as well. That really we try to give what I would assume is the kind of information that you might be interested in. So you might visit CMDC and look for that offering. Although, admittedly, I don't know if Archimedes, Bill, if Archimedes does a workshop like that, but Archimedes does many public workshops, and there are other institutions and organizations that do workshops on cybersecurity, broadly cybersecurity, and certainly medical device cybersecurity. So it doesn't have to be CMDC. We'd like it to be, but it doesn't have to be, because there are plenty of various sized courses that you can take. Some of the speculative viability or cost of adding regulation. What are some of the speculative viability or costs of adding regulation for devices to have a security expiration date? So many consumers are, interesting. That's interesting. So the notion that there's an end use date for medical device based on some security aspect.
I could probably tell you how the FDA would answer that. In that they do that in some cases. There are certain medical equipment that does expire, but generally speaking, they're not going to use regulation to solve that problem. I mean, the assumption is that healthcare providers and hospitals and manufacturers are always going to try to do what's best for the good of the patient. But I'm sorry, I have to come back to that same question again. It's about the money. It costs a lot to replace capital equipment. Now, if it was a matter of a device in somebody's body, for example, I mean, obviously, if it was not functioning, or if there was another functionality that it came along with, I can tell you my wife has had multiple ICDs, and at one point they replaced it because the newer ones had some functionality that she needed to keep her heart viable. So in those cases, that does happen. But I think that as long as it's still doing the job and doing it right, and it's still functioning properly, unless there's a medical need, I don't think there's any reason why it would get changed. And again, I think it's the money. So I would say.
Yeah, and you could argue that it would be imprudent, again, it would be imprudent to sort of preemptively remove otherwise good devices from service, particularly if they're implantable, because of the risk of doing so to the patient and just the overall cost to the healthcare infrastructure. So I think for me, it would be tied to having some real understanding of threshold of risk that would require it to be removed from service. And Bill, Bill's described some notions about what drives that, and it would be degradation. Either some critical function is added or degradation of service to a point where it produced risk. That can be hard to know. Are remote software updates to medical devices a practice that is used in any capacity? What type of regulation do these upgrades need to go through, if any? I'm going to give that to you, Bill.
Absolutely, yes. And in fact, it's happening more over time. A lot of the updates are done manually. For example, field people, like from a manufacturer, would go to a hospital or indeed help with the update of the software for a device that might be implantable or for any big hardware, et cetera. And even more of those now are happening over the network, right? And what regulation do they have to go through? Well, think about that. I talked just briefly about that post-market guidance. It talks a lot there about the need for it to be done, the preferred way that it should be done, making sure that it's tested, making sure that there's post-implementation testing that goes on. And then of course the clinical security folks, if it's at a hospital where the update is being happening, they do testing as well to make sure, just like any good software or IT developer, IT person would do, is when you apply an updated piece of software, you test to make sure that it's viable and that it's operating correctly. So it isn't as much as it would like to be, but over the last 5 or 6 years, a lot of progress has been made by manufacturers building that capacity into, even in some cases, older devices, but building that capacity into devices, and they have to follow the post-market guidance that the FDA has directed.
I don't see any questions in the chat box, but subject to Kevin's direction, we're willing to take, obviously happy to take other questions if they're in the room or online or whatever.
So when independent researchers discover vulnerabilities in medical devices, those independent researchers typically disclose that to the medical device manufacturers for free, or do they charge some form of consulting fee or something? Because otherwise, what is the motivation to disclose these besides academic notoriety?
That's a very good question. I can say that has shifted over the last 5 to 7 years. Initially, when this started happening 5 to 7 to 8 years ago, the biggest problem was that a researcher would find something and they would try to contact the manufacturer, but they didn't know who to talk to. And they might try to call and send emails, and it took forever, and the manufacturer had no way to process that. It would never get to the right person. And then they would get frustrated, and then they would either go to the press or they would go to the FDA, and that's how these things made such press notoriety. And it made the manufacturer look bad. It's like, I tried to talk to Medtronic, I tried to talk to Boston, whatever. Well, that's changed dramatically in recent years for 2 reasons. One is that the motivations for the researchers doing it has changed. Initially, it was notoriety. Sometimes they would get a small reward, that the company might give them $1,000 to thank them, as well as posting their name on their website. Thank you for finding that for us. Now, typically these folks, there are fewer independent ones, and more of them are working for consulting companies who indeed will sell their service or go to a manufacturer and say, hey, we'll help you, but we're going to charge a fee or something like that. But the other thing that's changed is manufacturers now have a incident response process. I don't know if that's exactly the word they use, but an incident response process. In fact, you can go to most of the manufacturers' websites and you can look up incident response. But they have a process that you can go to their website, you can download any data or software or code that you want to share with them, you can send it securely. There are people sitting waiting to process that type of stuff. The right people from the security teams, from the R&D teams, from the legal teams that know how to process that well. So it's much more of a highly sophisticated process than it used to be. So the motivation, there are indeed, in fact, I know this, I believe this to be true. There are people that are simply doing it to be altruistic. They really believe that there are some risks out there and they really want to help people in healthcare do better. But in the end, there's more profit in it now than there used to be.
It's This is conflicting for me, because when I think about healthcare research and my own sort of academic research into disease and its treatment, what's the right model here? I think about, for example, if I, as an academic researcher, well, much of my work was in restenosis, but if I, in my research lab, had found out some critical information about, let's say, the toxicity of a drug, what's the mechanism, and was there ever a time when perhaps I would have been motivated by profit to not disclose it, or disclose it exclusively, or to contact the manufacturer to say, I found something about your drug, I'm only going to tell you if you pay me. I think, in a way, I hope we don't get to that level of desired monetization, right? I think, however, the path I might have taken and did take at times was, I know how to improve the drug, I'm going to file a patent on it. And so I think, in a way, there is in theory a way to do this that is both sufficiently altruistic, but protects one's own intellectual property and the good work that you do, and that is maybe by a mechanism that would allow you to protect your knowledge before you disclose it, but not extort, what sounds a little bit like ransomware. It sounds a little bit like extortion, right? I'm only going to tell you how to fix your device if you pay me. There might be other more subtle ways to do that ensure that you get some compensation without it putting people's patients at risk by withholding something, if that makes sense. It's a subtle thing.
No, I think you're right on, Dan. And in fact, I'm trying to think, I don't recall there ever being a case where I heard that.
Yeah.
Well, I'm not going to tell you unless you give me a bunch of money.
Right.
I don't think that's ever been the case that I'm aware of in my experience. It was always either altruistic or, yeah, I'd like some recognition. Or I remember, in fact, one guy, we sent him a bunch of Medtronic sweatshirts and he was happy as heck about it.
Yeah.
That was about it.
Yeah. If, on the other hand, it's something that becomes intellectual property, then I would encourage, and I know software is notoriously difficult to at least I understand it's notoriously difficult to protect. Not impossible, but difficult. It is to understand how you can, so that you can protect your intellectual property and maybe even benefit more than you might ever imagine by improving on a security protocol, its implementation, on some aspect of it, so that you make the fix available, but you own the fix. It's clear through copyright, patent, or other things that you own it, and your disclosure doesn't put you at risk. It makes it available actually to all manufacturers, ideally, because there might be others. You may have identified a vulnerability in one product, but if you tested 5 or 6 others, there's a good chance they might be vulnerable as well. So who knows? But yeah, I think it's a great question, particularly coming from students entering the workforce and wondering how that works.
Yeah, I'm not actually a student. I'm an implantable firmware developer at Medtronic.
Ah, okay.
Seminar looked really interesting to me, so I decided.
Okay, thank you.
Any other questions? All right, well, thank you. Darkness, all of a sudden.
You've been hacked. You've been thrown into darkness.
We were all sitting too still.
That's funny.
Thanks, everyone. Thank you, Dan. Thank you, Bill. Thank you, everyone, for attending. We hope you got a lot out of it. For those of you who were contacted through one of our communication methods, expect a feedback survey not too long from now. Have a good rest of your weekend.
Thanks, everybody. Bill, thank you. Kevin, thank you again. Have a great weekend, everybody.